Ryan Stanton here with ASEP Frontline. Today joined by Dr. Stephen Dorner and Dr. Emily Hayden, and we're going to talk about something that actually, and interestingly, was a response to COVID-19, but actually has significant play and viability with regard to the recent study with the future workforce of emergency medicine. And we're going to talk about the COVID Virtual Observation Unit, and both of them are up at Mass General, up in Boston. And we wanted to talk about that and how this evolved and really how this may play out moving forward, because I'm pretty sure, 100% sure, that this is not going to just stay within a COVID realm, that it's going to expand very quickly into other areas of potential utility and opportunities within the House of Emergency Medicine. So, Dr. Dorner, Dr. Hayden, let's start off with just getting a little bit of background, and we'll go from there. Dr. Dorner.
Yeah, thanks, Ryan. So emergency medicine physician here at Mass General, and currently a fellow with the Mass General Physicians Organization, focused on policy and management, and have been organizing some of the alternative care pathways for taking care of patients in the home-based environment and leveraging both telemedicine as well as mobile integrated health. Since I started this past July, I'm working with Dr. Hayden, who I'll let introduce herself.
Awesome. Thanks. Sorry, Ryan, I'm going to jump right in. So I'm Emily Hayden. Yeah, I'm emergency medicine also there at Mass General. Have been there about 15 years, and about 5 years ago switched or pivoted over to telehealth, and have been really trying to figure out how telehealth as a tool is going to be shaping emergency medicine, and how emergency medicine should be taking this tool of telehealth to really create the future for our specialty.
And actually, that's no problem whatsoever. Dr. Dorner did the actual transition, so he did what I was going to need to do, which was just kick it over. So it's not a problem whatsoever. That we feel free. We're an open conversation. It's like we're just sitting out at a restaurant somewhere, which I guess we can do now at least a little bit with the drop down in some of the COVID numbers. But this all evolved as COVID came around, new virus, everybody's panic alert red kind of stuff. These cases going on, and we're looking for alternative care models in terms of ways we could take care of patients considering COVID. And so this observation unit, virtual observation unit, was born. So let's talk about how that came about, how things transpired. And I'll start with you, Dr. Hayden.
So I think that I don't know if I would be using the word virtual observation unit. I think this is more of a, we called it a virtual observation unit, but felt like, this is more of, it's remote symptom monitoring, and trying to take an opportunity for patients who are going to be isolating at home with COVID, who are scared, who are not feeling well, and how to keep them out of the emergency department for both capacity reasons as well as for the infection control reasons. So we really wanted to figure out how to be using some of this remote symptom monitoring, remote patient monitoring, and that also Stephen's work before even COVID hit was working with the mobile integrated health space. And so he had this great idea of trying to pair remote symptom monitoring with the mobile integrated health. And so Stephen, I'll let you, because this was so much of your passion project. So Stephen, I'm going to let you take that from here.
Yeah, so I was still a resident when COVID came around the first time. And my background before I had started residency was in the health policy space. And when I'd done my master's in public health up here at the Harvard School of Public Health, I'd worked with this organization called Commonwealth Care Alliance that had launched the state of Massachusetts, or Commonwealth of Massachusetts for that matter, the first mobile integrated health program in the state. And I'd gotten that up and running, and then came into residency. And as we were sitting in meetings talking about COVID, and we'd been discussing getting a mobile integrated health program up and running at Mass General, which hadn't existed yet, I thought, wow, this is a phenomenal opportunity for us to help offload some of the capacity challenges that, we were looking at New York and seeing what was happening to the hospitals there. And as we were trying to come up with solutions of how to avoid that from happening here, thought that's a great role for MIH. And so during our first surge, we had built out MIH for exactly that, evaluating patients with respiratory symptoms that we thought could be related to COVID, or that we knew were related to COVID, so that we could identify if those patients had oxygen levels that needed to be hospitalized, or if they had work of breathing that was so severe they needed to be hospitalized. Because during that first surge, we really didn't have any treatment options. You either got intubated or you didn't. When the second surge came around, we knew we needed to scale that. And so building that out of emergency medicine and pairing it with the tools that we had for monitoring symptoms remotely, integrated with our EHR, so that we could identify patients who were positive for COVID, enroll them in a symptom monitoring program, have a team of nurses that were screening those symptom reports on a daily basis, and then being able to escalate that up to an emergency physician who could then dispatch a paramedic who would facilitate a virtual visit while in the patient's home, get a full set of vital signs, and then make the determination about if that patient needed to come in for either advanced imaging and a evaluation for a PE, or if they needed to be admitted for initiation of steroids and consideration of remdesivir, oxygen therapy, what have you. So that's how it was born. It was really a year in the making, pulling together different pieces and strategies to package it together as this cohesive program. And then we ran that from January 12th through April 2nd was when we discharged our last patient out. And that's kind of the story.
But you mentioned that we've had this full life cycle of this iteration of the symptom monitoring unit. But I see the potential, this huge potential, because so many people we see in the emergency department, most discharge somewhere between 75 and 80% of the patients that you see, some higher, some lower, depending on your care setting. But a lot of times we give the instructions. In fact, we give the instructions to every patient, even though those that we know really probably don't have anything that big going on. Things get worse or you get worried, come back in and we can reevaluate you. And then we're sending the patient home with a lot of questions and a lot of fear. And actually, you guys touched on that earlier, that these patients with COVID, especially early on with a new virus, everybody was scared and going home and what was going to happen. And I feel like many times we ended up admitting people because they bounced in 3 or 4 times because they were scared and not necessarily because they met any metric. There's that point where in emergency medicine, you start saying, well, the risk isn't worth the reward here for me to continue to push this patient back out the door, even though we know that more than likely, everything's going to be just fine. And so we tell all our patients, come back in, you get worried or concerned. But we don't have a way of looking at it. There is some monitoring from cardiology that takes place remotely. But this is actually the first way of saying, we've evaluated you, establishing the program, and then we're going to monitor you until we reach a resolution point and help guide you through this process instead of just making you depend upon somewhat non-specific EHR-based discharge instructions that have very little in terms of specifics. And many times in emergency medicine, we're just trying to get something that is even within the sport, not much less the ballpark of what we're trying to discharge them with. So talk about this potential future and next phases that we may see with regard to this type of model as an opportunity for emergency medicine to further spread its wings and take care of our patients. Dr. Hayden.
Yeah, so I think you're bringing up some great points there. And I think that there were some definite lessons learned when we did this. I mean, when we stepped out to do the remote symptom monitoring and then pair this with the mobile integrated health, this was stepping out from beyond the triage desk. Like, this was something different for us as emergency medicine physicians to be not handing the discharge paperwork and saying good luck. We were following these patients, and so I think that we want to make sure that we're not missing that there was this piece that as emergency medicine, what is our identity as an emergency medicine physician? And we're used to dealing with patients that come through our doors and not following up. And so for this covert remote symptom monitoring, we were following patients for 14 days with daily symptom trackers. We also had nurses who were used to doing floor emergency medicine and were then all of a sudden having to figure out how do you walk the virtual floors. And so there were so many pieces there that we learned on the COVID symptom monitoring, that these are all pieces that can be applicable to so many different aspects of emergency medicine, depending on where we want to go with this. I think this idea of us being the like you said, that there's cardiologists that have some type of remote symptom monitoring, and that we as emergency medicine are the ones that could be responding to these escalations and pathways. You might have endocrinology, cardiology, all these other ones in our healthcare systems with remote symptom monitoring, and somewhere in that escalation pathway says, send this patient to the emergency department. And so is there a way that telehealth or maybe mobile integrated health could be plugged in there for emergency medicine to be able to see these patients in the acute and scheduled care needs, but they're not coming into our bricks and mortar ED? And so, like you said, the potential, there are so many potentials of this, but I think it also is going to take a philosophical step back of what is our identity, what is our value, what should we be doing in emergency medicine going forward now that we have these tools. So.
Dr. Dorner, I assume you're not retiring at this point now that you've had your full generation of your baby here. So what's your next step and phase?
Yeah, so we're looking at it from two standpoints. There's the kind of the pre and the post. How can we capture patients upstream from the emergency department to identify the level of need of care for that patient and direct them to that appropriate site and level? Really extending what we already do within the confines of the emergency department and moving it into the pre-hospital world. And then the second is for exactly as you were referencing, the after we've had that initial evaluation, the what's next. So one of the opportunities that we've been talking about with our clinicians within the ED is, if you would be comfortable sending this patient home, as long as you had a planned next day visit, that's a perfect patient that you can send with this program, because then you don't have to keep them in the hospital overnight. You don't have to just get one more check on them. We can send out a paramedic. We can do point of care labs. And we're not leaving it up for the unknown of, well, you'll just follow up with your PCP within the next 3 days. We are the follow-up that we're pre-scheduling for the next day. And I think it sets up a lot of opportunity for us to integrate more and collaborate more with our colleagues in the ambulatory space. There's such a disconnect so much of the time between how outpatient clinicians want to use the emergency department or their lack of resources for acute unscheduled care, as well as for following up on what happens out of the ED. A lot of folks consider what happens during an ED encounter to be a bit of a black box and not really know what happened to the patient. This allows us a pathway to not just have that acute episode of care evaluating and treating the patient, but then being able to facilitate the transition in the outpatient space where we've conducted the follow-up with them and we can have a handoff while the patient's back at home. I mean, one of the things we've been talking about is the whole concept of a safety assessment. How many times do we assess patients in the hospital and say, well, we need to make sure that they can pass a road test before they could go home and make sure that they're not a fall risk. Well, assessing a fall risk in a clear hallway is a completely different picture than assessing a fall risk when they're in a home that has rugs and furniture and cats and dogs and who knows what else that may be running around posing potential risks. So really just changing the whole nature of, not the nature, but changing the environment in which we're performing the same evaluations that we're already providing.
And it's very interesting that this all came about. I mean, this was all a response to COVID-19. And as the United States numbers have dropped down significantly, they're planing out right now. Some are ticking up just a little bit, but definitely not the levels we were seeing in December, January, and February. It had a purpose then, but now it's gained a new life. I mean, we've all seen, we all understand that the least flexible part of our healthcare system is the bricks and mortar that make up the emergency department. There's only so many ways I can split up the 30 rooms that I've got in my emergency department. And if I've got 45 people needing to be seen, that means 15 we're going to have to either, secondary waiting rooms after initial evaluation, whatever it may be. Everybody has their little ways of dealing with it, whether it's hallway beds, whether it's fast track, rewaiting, bouncing people around. But at the same time, it's still not very flexible. I mean, we can make plans that say we're going to expand the emergency department, but that plan's going to take months, if not years, most likely years to come through. And by that time, you're already behind again. But this gives the opportunity for us to add virtual emergency department rooms And, when we're feeling that pressure to say we need to get a bed available and send this person home so we can make room for the next patient who's waiting, we have that opportunity now that we don't have to have that worry about how long we're going to watch them to see how that disease process that may or may not and most likely doesn't advance is doing. I mean, I could see, that minor, let's just say, just for the sake of a better term, that minor head injury, that kid that we may want to watch for 4 hours or 6 hours, being able to just keep an eye on them in the comfort of their home, because everybody knows that their kid comes in, they get evaluated. We said, we want to watch them for about 4 hours. The family is like, well, can we actually just do 30 minutes and go on home? Should we let them sleep? Should we do all this other stuff? There's a lot of different ways that it can do that. But then came the workforce study that found that emergency medicine, we're going to be overpopulated of physicians, board-certified emergency physicians, probably crossing that mark here in a couple of years, but a significant overflow of physicians by 2030. And looking at some of those options, one of those options that has been put on the table is expanding the scope of practice. And this has happened in other professions, whether it's anesthesia, whether it's radiology, whatever it is, that expansion of the scope of practice. And ours has been doing it throughout the decades of emergency medicine. I mean, we initially weren't allowed to intubate. We weren't allowed to do any procedures. We weren't the ones putting in deep lines. And yet our scope of practice has been steadily expanding as our expertise expands. How is this a potential transition in the future of emergency medicine, as emergency medicine, not only, as Dr. Hayden, you mentioned, the home of the episodes of acute care, acute need for healthcare, but also the entire acute care spectrum of saying emergencies don't just happen in the emergency room. They are potential emergencies happening all over the place. And you see it with emergency medicine getting more and more involved with EMS, wilderness-based medicine, event medicine, sports medicine, areas like that. How is this a next transition, a natural next step with regard to emergency medicine and home monitoring, symptom monitoring, virtual observation units, whatever it may be, whatever you may call it, with the future of our specialty? Dr. Dorner.
Yeah, you're exactly right. I mean, it started before the pandemic that we were seeing a huge market shift into the home-based care space. We saw health systems like Mayo make massive investments in wanting to build home-based care. And then we started seeing these disruptive innovators like Dispatch Health and Medically Home enter into the space and really change the way that people were thinking about this care. And the pandemic happened and it shifted everything and made things move so much faster, to the point that they made Congress and CMS move faster and create regulatory and reimbursement models to support this exact kind of care. So, that framework that CMS put in place is possible through the end of the public health emergency. But when that ends, all of us as a nation, and especially as a specialty, are going to have to figure out, well, what do we want this to look like looking forward? And I think that with the patient demand and the market shift into home-based care, with a clear mandate that Congress is going to have to figure out some way to change the reimbursement frameworks to facilitate and support home-based care. What then is the role for emergency medicine, and how do we carve out a piece of that puzzle in that environment, so that, in a lot of ways, we're going to have the same battles that the first emergency physicians had when they had to carve out emergency medicine as a distinct specialty. A lot of folks don't think about emergency medicine and home-based care. It's not really the first thought that comes to mind. But once you get into it, and once you start thinking about, well, mobile integrated health and telemedicine and pre-hospital care, that's all in our wheelhouse. And so why wouldn't we have a role in home-based care and thinking about the creative ways for us to plug and play our skill set into that environment?
Dr. Hayden.
Yeah, I completely agree with that. And I think we as a specialty should also be aware that even with these changes, the tools of telehealth, with mobile integrated health, not only is our specialty seeing this as an opportunity, but so is every other specialty, or most of the specialties. And so while we're thinking about what can we be doing, how can we be using the tool of telehealth to provide care in home, or try to do other coordination of care, or maybe deflect some patients from being able to, or having to come into our in-person EDs, this is also happening in primary care specialties, subspecialties, and they're all creating their own virtual care. Care. And so I think this is something that we need to be very aware of that, and that we need to, just as Dr. Dorner said, we need to be there advocating for where we should be in this space. And so we're already feeling the pinch on the not only the workforce study, but the pinch of the ED volumes being down. And that some of that volume, I don't know if we have the data to back it, but some of that volume probably is that these patients are going to the new virtual care opportunities and other urgent cares and other primary care specialties. So I think we really need to make sure we are experts in acute unscheduled care. We are experts with EMS and pre-hospital. We are experts in getting the right patients to the right place at the right time. And that we need to make sure that not only we as a specialty know that, but that our health systems know that. Because for the changes that are going to happen, and for some of the advocacy that's needed to change the regulations with CMS, to change the regulations in this healthcare systems, they need to see us as emergency medicine as having that skill set and that value to the system. And I fear that we may be keeping this more within our specialty than making sure that others know this too.
One of the big challenges that I can see is that we are the emergency board certified emergency physicians are the specialist of the unscheduled acute episodic care. And I can see a lot of people's minds turning out there with the potential that this would turn into another opportunity for administrators to assign this to those that may not have the expertise and ability to contextualize and work through the process that is going on. And I think we all see that. I think we see the mighty dollar driving a lot of the care models out there, and we see a lot of referrals to the emergency department that are unnecessary, care that's provided that is inaccurate or not realistic. There was just a post that came up about an emergency physician that's frustrated because a patient was diagnosed with anxiety when it was a post-orthopedic procedure, massive PE, ended up coming to the emergency department in cardiac arrest. And after being dispositioned from another walk-in type setting. And those are the things that I'm concerned about, is that, though this is a fantastic idea and work product of Dr. Dorner and Dr. Hayden, my concern is that our systems are going to now say, well, let's put somebody in front of this screen, in front of these work products that doesn't have the training and expertise to actually apply these and due to that critical thinking that is necessary to get the best and safest outcomes for each and every patient that comes across the screen. What are your thoughts on this needing to be a product that is led and administered by board-certified emergency physicians with regard to the acute episodic care patient, Dr. Hayden?
I think you're spot on that there are going to be opportunities, and not opportunities, but there are going to be situations in the future where, if this is something that bears out to be revenue generating, or has the good data behind it that it's saving ED visits and saving and increasing quality of care, that yes, there are going to be situations where providers who are not probably up to the skill level to do this are going to be put in that situation. I think that in the beginning we need to be very careful of that, and I do think that emergency medicine, board certified emergency medicine, is where this should be landing initially while we're trying to figure this out. Like, I do not think that it's safe for others to just be put in front of the screen and saying, hey, the paramedics are there, can you go ahead and start helping this patient out? I think it could work in some situations, but there are that acute unscheduled care that we're so used to, that I do think there's value in board certified EM physicians leading this currently.
And Dr. Dorner, you being one of the young generations of physicians out there that are looking at these numbers that are out there for the workforce studies, and not where I came through, and I'm not sure when Dr. Hayden finished training, but for me, being in emergency board certified for the last 13, 14 years, there never was a big shortage of opportunities out there, really, as long as it wasn't a really big city. Even there you just the market may have been depressed a little bit, but never really had to worry about that. For you, same question with regard to this application of emergency physicians, but also opportunities for you and your colleagues moving forward as young physicians.
I totally feel the stress that a lot of my colleagues are feeling, that we went into training 5 years ago, in my case, at a time when this was not on the horizon. We were hearing that there was going to be a shortage of physicians when I started residency. And then we finished residency, and all of a sudden the environment has completely changed. Not only was there a pandemic, but now there's going to be 10,000 too many of us in 9 years. It makes you have to think about ways that, one, how can I innovate in this space? And how can I broaden out and really emphasize the importance of why I went into this in the first place? The second is that I think we need to do some really critical analysis around where is a physician really needed. And these are not simple cases once you get into patients' homes and start performing evaluations. You find yourself having to coordinate complex situations. You find dropped balls left and right that you have to pick up and be responsible for. And a lot of that really ties back into the skill set that is unique to board certified training and having gone through an emergency medicine residency that others wouldn't necessarily have. And so I agree with all of the points that both of you have made, that there's a real imperative for us to critically think about what this space should look like, and how we can carve out the space for all of the new grads and the grads who are still in residency and going to be continuing through training as more and more of this information starts to come out about the workforce and the changing environment.
And I think a lot of times, that there's a lot of folks who agree that everybody should have access to care. I think one difference with us and everybody on this call is we feel like that everybody deserves access to the best care, the most highly qualified and specialized care that has the exposure, time, and experience to be able to put the entire picture together for that patient. Because not only do we need to be able to identify emergent conditions that may deteriorate, but we also need to be able to understand the best care plan, explain that plan, the next steps that are going to take place, also avoiding unnecessary and potentially risk introduction of the evaluations that we do. I mean, there's a lot of stuff as we evolve in emergency medicine that are going to be very important and key points. And I think these mobile and home-based units are going to be an integral aspect of the fact that we just can't park people in the hospital anymore. We can't just leave people sitting there for 12, 24, 48 hours when we can accomplish those things in their home setting. The patients are more comfortable. A great example is a patient that comes, an elderly patient with dementia. We put them in the hospital, and it is a downward spiral that lasts for weeks with the sundowning, the new environment, everything that happens. We just put them in for observation to make sure that the antibiotics for the urinary tract infection kick in and do everything they need to do. But now we've got a patient that is with us for a week because of all the complications and issues associated with being in the hospital in new settings, sundowning, agitation, all the things that have happened, when we could very easily accomplish that with assistance and monitoring in the home or long-term setting. And so, I'd see this as a huge opportunity moving forward that not only is better for emergency medicine, but also better for our patients and better for our system in general as we move the patient closer and closer to where they are and where they need, as opposed to making them try to fit into our pre-established, the way we've always done it type system. Any closing thoughts from either of you as we transition forward and wrap things up today? Dr. Hayden?
No, I just agree with you, Ryan, about the trying to really think about this more with patients being at home. I remember there was an article that came out with the idea of, trying to decrease the home-to-home time of 0, that a patient, when are we going to be at that day when a patient who would have come in the past to the emergency department with, diagnosed with community-acquired pneumonia, wasn't ready to go home, had to be admitted to the hospital. If they had the issues with dementia and sundowning, all the other comorbidities that would happen with the hospitalization. And there is a future where we can help lead this, where a patient could actually have the evaluation that would be the emergency department evaluation there at home. And then we can transition them to some of the hospital at home programs for an inpatient stay. And that home-to-home time was zero, or it becomes zero for this patient. And so there are so many opportunities out there that emergency medicine, I think we need to really think about, where do we as a specialty want to be when we're going out from behind the triage desk, as well as, where is our scope of practice best used in some of these new tools too. So I'll let Dr. Dorner have some words also there.
Yeah, I mean, we could spend another half hour on this next point, but I think we'd be remiss not to include the element of inequity in healthcare delivery as we branch into the home environment. Not every patient's going to be able to get onto their tablet and connect to their Wi-Fi to have a virtual visit with their physician. And using mobile integrated health and dispatching paramedics who can bring that technology into the home and be able to bridge some of those gaps in access to care can address some of the significant inequities that have been augmented and highlighted through the pandemic as telehealth has emerged as such a significant driving force in addressing capacity challenges, et cetera. And so I think having that lens as a potential driver and solution for addressing inequity in this space is going to be really important for all of us to consider as we think about the innovative ways for us to branch into the home-based care environment and continue carving out the role for emergency medicine.
And if you've not experienced what Dr. Dorner is speaking about, working as a EMS medical director, being out there in the home settings with EMS as they go into these houses, apartments, and dwellings, and seeing the challenges. I mean, it's one thing right now. In fact, my wife is actually downstairs right now doing virtual visits. She's doing with her clinic. It's still left over from COVID, and we've dealt with, and I've heard her stories of challenges with access and Wi-Fi and devices and all of those things that folks struggle with. And we assume many times, unfortunately, that everybody, especially if you're very fortunate and you've got a nice home and you have all of the technology and great Wi-Fi and all this stuff, you take for granted that everybody's got that everybody has access to things. And when you go into these homes and you see some of the conditions and some of the challenges that people face on a daily basis, it really is there's no, I mean, you understand why there are so many challenges and why folks may not be getting better, why they may not be able to follow that care plan that you established or whatever it may be. The expectation is that everybody has all of the technology and all the experience and all the skills necessary to do everything and anything we say to do from the ER, and it just isn't necessarily the case. And as we see the utilization of community paramedicine, the idea of us being able to spend time at home. This is going to be the new version of what everybody misses from healthcare, which is the house call, the home visits. When you had your doctor coming into the home and kind of seeing you where you are. Norman Rockwell didn't paint pictures of people in trauma room 12 with all these lights and sterile things all over the place. And of course, back when he was painting, there weren't computers, but computers all over the wall and people coming and going and housekeeping coming in 18 times to empty the trash can. He paints pictures of people, in their home and the care that they're receiving. And, that's really one of the things that as us in healthcare can do is reconnect to that, but using the technologies that we have to make it efficient, to make it cost and time efficient to where you don't have a physician traveling, across town 15 times a day. We can just transition from room to room to room and taking care of these patients. So how can folks get in touch with you guys if they have any further questions, thoughts, or consideration of actually how to implement this in their home location? Dr. Dorner.
Yeah, please reach out on Twitter. I'm at Stephen Dorner. It's Stephen with a PH, Dorner like corner with a D. Or look us up on our on the MGH website and shoot us an email. Both of us are happy to chat about this, looking for collaborators. This is going to be a group effort as we move into this new territory, and it'll be better if we all do it working together.
So I have to laugh. Even though I'm in telehealth and technology, I don't have a Twitter handle, feed, whatever you want to call it. And I don't have a LinkedIn page yet. So just go to the website, or my email's emhayden@mgh.harvard.edu. And happy to chat with people. I could chat for hours on this one. So just be warned, if you reach out, it's going to be a longer and good, rich conversation.
Twitter is a fantastic place to chat. I mean, that may happen. I still remember when I would go to the SMAC conferences, and everybody had a Twitter handle, and that's how everybody communicated. That was actually their identification on the name tag. And then coming back and working with emergency physicians locally, and like, here, you can tweet us. And nobody had a Twitter account. Nobody had a handle or anything of that nature. And I know that we're just on the audio aspect for all the people out there, but Dr. Dorner has every bit of the fellow status going there with the mobile temporary walls, a couple of schedules on the wall. You don't even have a way to get the dry erase board attached. Of course, earlier we heard that he's still in the hollow door aspect of the hospital. One day you're doing a fantastic job. It's not going to be long before you're going to have an office with a solid wood door, and we'll celebrate that because you're moving emergency medicine forward. And I thank both of you for joining us here. As for me, you can join me on Twitter at EverydayMed. rstanton@acep.org, rstanton@acep.org. We have our Facebook page for ACEP Frontline, and also encourage you on whatever platform you like to subscribe to the podcast so you can get every weekly episode. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.